So Dr. Raghavi has given the answer, pneumonia causing type 1 RF,
Definitely.
Alex, COVID, and Dr. Raghavi again, atypical or viral pneumonia.
Yeah, and Alex has said it is COVID.
Yes.
Definitely, yes, you all have depicted the right kind of diagnosis. The patient is having severe kind of respiratory failure. Sorry, not severe at the moment, but she is having severe symptoms with type 1 respiratory failure at the moment. The CT chest is showing bilateral extensive opacities, more so in the upper and the posterior parts of the lung, with some amount of ground glassing as well as consolidation patches. So bilateral involvement of lungs. Patient is hypoxemic. So definitely this patient is in ARDS. Now ARDS could be caused due to n number of reasons, which could be present inside your lungs or outside your lungs. So this is known to everybody. Pneumonia is the most common cause of ARDS. The pneumonia could be viral, bacterial, atypical bacterial, or even in some cases of tuberculosis, sometimes we do get 1 or 2 patients who present as ARDS. If we see the type of hypoxemic respiratory failure, what is the problem which is happening in type 1 respiratory failure in case of ARDS? Now, the simple way to explain it is that this alveolar surface, which is on the left hand side, it is the normal alveolar surface, which is showing you type 1, type 2 cells, alveolar air space. These are the type 1 cells which are flatter. These are type 2 cells which are responsible for manufacture of your surfactant layer, which keeps your alveoli opened up with their surface tension mechanisms. And inside you will find these kind of WBCs and alveolar macrophages, which are present in your normal side of the lung. So this is the epithelial basement membrane. This is the interstitial tissue in between your alveoli and the blood vessel, which are the capillaries. Now this is the endothelial cell of your blood vessel. This is endothelial basement membrane. This is red cell flowing inside the blood in this capillary. And these are the fibroblasts which are present in your interstitium. So this is something regarding the normal lung. Now, what happens in ARDS? In ARDS, there is filling up of your normal alveoli with some fluid. Now, this is non-cardiogenic pulmonary edema, which means that your heart is absolutely normal, your LVEDP is normal, but still your lungs are flooded up. Your lungs are filled with a fluid which is not letting the gas exchange to take place. And as you can see, there is edema and inflammation all over. So what happens? There is this protein-rich edema fluid which is accumulating inside your alveoli. There is sloughing of bronchial epithelium. The cells disintegrate, they lose the connection and the crosstalk between them. There is necrotic or apoptotic type 1 cell, which is eating away all the other cells. The red cells, because of leakage due to the inflammation, is leaked inside this fluid. This you can see is an intact type 2 cell. On the other hand, you can see the denuded basement membrane, which was very well intact over here. And there is a hyaline membrane, which is taking a huge chunk of this space wherein the gas exchange is taking place normally. So this thickness is very, very increased. Hence, the flow of gases is affected between the alveoli and your capillary membranes. Also, there are migrating neutrophils with leakage of proteases, widened edematous interstitium with procollagen leaking in. There is gap formation between your capillaries. They lose their crosstalk. There is accumulation of all the inflammatory markers, which includes these TNF-alpha, IL-8, IL-6, IL-10, and IL-1. Also, these white cells, which is platelet activating, release these kind of factors, the proteases, platelet activating factor, the leukotrienes, and cause increased amount of inflammation. The surfactant also somehow in this kind of fluid loses its function and is accumulated somewhere else, not causing the proper opening up and elasticity of these alveolar membranes. That is the cause for their non-function and dysfunction. So you can see everything is swollen up. There is accumulation of platelets because of the leukotrienes, and all the inflammatory molecules which are released into the blood circulation. This is a neutrophil which is trying to go out and catch hold of the inciting agent. Everything is swollen up, including the inner lining of your blood vessels. So what are the causes of type 1 respiratory failure? It could be an alveolar problem wherein we have seen the accumulation of fluid, pus, destruction of the membrane, which I showed you, the hyaline membrane formation, very, very common in children, or the collapse of the alveoli is causing the whole problem. Now, it could be circulation problem wherein the VQ mismatch is the main mechanism by which the type 1 respiratory failure is happening. Very commonly, it is seen in pulmonary embolism, shunt related to heart, left to right shunt, and destruction of the blood vessels, which is there, which happens in certain cases of chronic respiratory failure, where there is the increased amount of tissue which accumulates inside these blood vessels, leading on to pulmonary hypertension. Or on the other hand, it could be interstitial problem, which could be due to fibrosis or infiltration of inflammatory cells and markers. What is the management of type 1 respiratory failure? We all know we need to start the oxygen therapy as soon as possible for patients who are in type 1 respiratory failure. Usually we do an ABG, we do a chest X-ray, because if the patient is very, very sick, we cannot move them into a CT suite. Then you should be doing a chest X-ray at once, a 2D echo bare minimum, because we need to know if their LVEDP is normal or not. And side by side, look on the causes which could be responsible for their type 1 respiratory failure. Also, the basic minimum investigations, the CBC, LFT, KFT, and the blood cultures need to be sent in these patients, because some patients do come in with infections wherein they are not able to mount the amount of inflammation which has to be there by the body because of dysfunctional or dysregulated response to the inciting agent, which is the reason ARDS develops in these kind of patients. So you should be looking for blood cultures, urine cultures, looking for the cause for ARDS, ruling out pancreatitis, and correction of that particular cause. Initially, somehow we do try to help these patients with continuous positive airway pressure therapy. However, this is not the recommended mode of therapy in case of type 1 respiratory failure. The severity is based on the PaO2-FiO2 ratio. The PaO2 is seen in ABG, and the FiO2 means that what is the amount or the fraction of oxygen which these patients are getting in. It is very, very easy to calculate. If your patient is on 2 to 4 liter, it is usually between 28 to 32%. This chart is very well available on the Google. I might say a wrong value, but you can corroborate. If the flow is between 4 to 6, then the FiO2 goes up to about 41 to 55. Then higher the amount of oxygen you are giving these patients with nasal cannula, a large part of it is actually leaked out into the atmosphere. So more than 50%, if your patient is requiring more than 50% of FiO2, then they need some additional form of respiratory